Muhammad Sheikh and I'm working as Associate Professor of Surgery at Surgical Unit 5. Today I'm going to discuss with you perianal diseases, specifically perianal abscess, fistula anal, and fissure anal. Before we move towards the diseases, first of all, I should discuss with you a little bit about the anatomy, surgical anatomy of the anal canal, and after that we'll proceed towards the diseases. So, what is anal canal? It starts at the end of the rectum and passes through the pelvic diaphragm and ends at the anal verge. So it's about 3 to 4 centimeters in length. It starts at the end of the rectum and ends at the anal verge.
सर
This is the
सर
part
थोड़ा
which we call anal canal.
सर थोड़ा तेज
And
बोले.
as far as anal canal anatomy is concerned,
Hello.
there is one terminology which is used, it's
Hello.
anorectal ring. The anorectal ring is present at the junction of rectum and anal canal, anorectal ring, and it's basically responsible for continence, and it's made of four muscles. Because of those function of the muscles, the continence of the stool is controlled. If something is disturbing, then usually might undergo incontinence. So these muscles are tuberoctalis muscle, deep external sphincter, conjoint longitudinal muscle, and internal sphincter. These four muscles make the spinorectal ring as a junction of between the rectum and the canal. You have to remember these four muscles. Spirorectalis muscle is part of the levator ani muscle, and this is the deep external sphincter. Conjoint longitudinal muscle is a continuation of the circular muscle of the rectum, circular muscle layer of the rectum, and it's the highest part. And then internal sphincter, it's also part of the circular muscle of the continuation of the circular muscle layer of the rectum. So over here, if you this is the diagram of the anal canal, and it starts from here. This is the junction between the anal canal and the rectum. Okay, and this is the rectum, the rectal roots. And
Hello,
over
sir.
there you can see this is the muscle
Hello.
palace.
हेलो.
जी
सर पीछे से ना शोर आ रहा है, तो आप थोड़ा सा
जी
तेज. सर पीछे ना मेरे ख्याल से और भी कोई क्लास हो रही है आपके ना, तो सर वहां से
हाँ, वो
शोर आ रहा
एक्चुअली वो जो हेडफोन दिया ना, इट्स नॉट वर्किंग, तो मैं भी डायरेक्टली उस पे माइक पे बात कर रहा हूँ, तो पीछे से भी क्लास हो रही है, 3 4 5 क्लासेस चल रही हैं.
है. जी जी जी.
तो
सर
अगर
तो फिर
आप इफ यू कैन
थोड़ा सा
वेट, तो आई कैन अरेंज दिस हेडफोन एंड प्लीज
सर
स्टार्ट
कर
अगेन.
सर कर लीजिए, अरेंज कर ले. हाँ
लो
ठीक है सर.
ये काम और सारी क्लासों की आवाज हाँ तारिक, कैन यू हियर मी?
यस सर.
अब ठीक है.
जी सर, बेहतर है सर.
ओके,
ओके सर.
so I was discussing anorectal ring, and that's the junction between the rectum and anal canal, and it's formed by four muscles. That's tuberoctalis, that's part of the levator ani muscle, deep external. Third one is which just got 3 parts: superficial, deep, and intraperitoneous. And this is called the third muscle is the conjoint longitudinal muscle, which is the continuation of the circular muscle layer of the rectum. And than the internal sphincter, as per the internal sphincter. That's also the continuation of the circular discipline of the rectum. So this rectal ring is the junction between the rectum and the inner. And this rectal ring uh, works like for the continence of the sphincter. This works. If the rectal ring is disturbed, then the patient might involve incontinence. This is the diagrammatic presentation of the inner canal, and you can see the junction. This is the junction of the rectum and canal, and this is the whole length of the canal. Just for this, this is the internal sphincter. Internally, it is and then this is the external sphincter. It's got three parts: deep, superficial, and subcutaneous. This is subcutaneous. Deep is superficial, and this is the groove between external sphincter and internal sphincter. We call it intersphincteric space. And this is the dentate line. What is the dentate line is that is the junction of the keratinoid squamous column, squamous epithelium and non-keratinized, which is coming on the right. So from here, the epithelium is keratinized to the squamous. This is the actual length of the anatomical length of the inner canal, the dentate, and this is the surgical which is going up to the inner rectal ring. And this is the anal foot. This is external sphincter. External sphincter, it has got three parts: deep, superficial, and subcutaneous. And this is internal sphincter, which is the continuation of the circular layer of the rectum. And this is perianal muscle. Above that is the muscle. So this is the complex of the sternum-column junction. Above that is the squamous columnar cells. The epithelium of the columnar cells. The rectum below is the squamous epithelium. This is another picture, another diagram of the rectum and inner canal. This is the whole rectum, which has two parts, include the upper and lower parts. And this is rectal ring. It's formed by the rectalis muscle. From above, this longitudinal conjoint muscle, internal sphincter. This is external sphincter. So external sphincter one part, which is internal sphincter second part, rectalis and conjoint longitudinals. These four muscles form this rectal ring, which has got for the continence of the responsible for the continence of the stomach. This rectalis muscle is part of the diaphragm, the ventral and it maintains the angle between the internal rectum and important component of the process, important component of continence mechanism. External sphincter again is from the bulk of the anal sphincter complex, and it has been subdivided into deep, superficial, and subcutaneous portions, which I have shown you in the previous diagram. Okay, this is the deep part of the external sphincter. This is superficial part, and this is subcutaneous part. So these three parts comprises of external sphincter. And this internal sphincter is the continuation of the circular muscle layer of the rectum. Upper part is the conjoint longitudinal muscle, and the lower part is the internal sphincter. In between these two sphincters, there is a potential space which we call intersphincteric space. Over here, the anal glands are there, and most of the abscesses are formed. Over here you can see this is the puborectalis muscle, which forms the invertebral ring. And this is the lavatory axis, which is the pubococcygous muscle, and puborectalis muscle. These three muscles forms levator anus. And the lower part, puborectalis, forms the part of the anorectal ring along with the other three muscles. Okay, so these two are the sphincters. Internal sphincter is basically is an involuntary muscle, and external sphincter is a voluntary muscle. Voluntary kind of. This internal sphincter is 2 to 5 millimeters thickened as a distal continuation of the circular muscle cord of the rectum. It is in the tonic state of the contraction. It stays in the tonic state of the contraction. It's involuntary muscle. It commences where the rectum passes through the pelvic diaphragm, about the inner orifice. So this is the difference between external and internal. Is that internal one is the involuntary muscle, and the external is the voluntary muscle. It's lower body palpable and intersphingeric. Okay. There's intersphincteric plane in between the external sphincter lateral and abdominal muscle medial and below internal sphincter. It exists a potential space, which we call intersphincteric plane. This plane is important as it contains intersphincteric anal glands, and if these glands become infectious, it may lead to abscess formation, and which travels from intersphincteric groove to the externally to the perianal skin, forms perianal abscess.
सर
जी
सर चैट देख लीजिए, क्योंकि स्टूडेंट्स कह रहे हैं कि आवाज़ उनको सही नहीं आ रही है।
आवाज नहीं आ रही?
सही आवाज़ नहीं आ रही है। वो कह रहे हैं कि जो है वो पीछे से मतलब पीछे से आवाज़ें भी आ रही हैं, तो कह रहे हैं कि जो है वो या तो जगह
वो
चेंज
अभी
कर
तो मैं
लेंगे।
यूजिंग दिस हेडफोन, और उसमें तो मुझे तो क्लियर इसी हेडफोन में आवाज आ रही
सर आपको आ रही है, लेकिन जो है वो हमारे पास जो है वो थोड़ी सी नॉइस आ रही है, मतलब पीछे से ना शोर आ रहा है।
है। वो तो हेडफोन की बात तो फोन नहीं आ रही, शोर नहीं चाहिए,
नहीं नहीं नहीं।
अभी भी आ रही है।
सर जी 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 सर, अब मेरे ख्याल से शायद पीछे किसी का फोन बज रहा है, वो भी आवाज़ आ रही है सर।
अब इसको क्या करें, वो पता नहीं चलेगा। इधर तो
सर
इतना
या
बड़ा
तो
हॉल है और यहाँ 6 लोग लेक्चर दे रहे हैं, क्या करें?
सही बात है सर, आप फिर एक काम करें सर, आप थोड़ा सा तेज बोलें सर।
तो तेज बोलो इसके
जी सर।
अंदर माइक, माइक भी मेरे बिल्कुल उस पे है।
जी 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 सर, आप बस थोड़ा सा तेज बोलेंगे ना, तो शायद पीछे की आवाज़ जो है वो थोड़ी सी दब जाएगी।
अच्छा, लेकिन पीछे की आवाज कैच करना नहीं चाहिए,
जी
हेडफोन
सर,
की
अब
बात करना चाहिए।
अब सर क्या कह सकते हैं, वो पीछे से तो
एक
आ
मिनट
रही है
मैं
सर।
और थोड़ा फिक्स कर,
जी
वो तो
जी
क्या
जी।
है कि पीछे की आवाज ज्यादा आ रही है। ये तो हम यूज ही नहीं, मैं यूज नहीं कर रहा। नहीं तो इसको अगर हम मैं ये यूज कर रहा हूँ तो इसका माइक क्यों ऑन है, तो इसको ऑफ कर दो। अब आ रही? हेलो?
हेलो।
हाँ, आ रही आवाज?
अब सर, अब आवाज़ आपकी बिल्कुल क्लियर आ रही है।
अब क्लियर है?
जी सर। और अब पीछे से भी सर इतनी ज़्यादा आवाज़ें नहीं आ रही।
हाँ,
सर अब पीछे से भी आवाज़ नहीं आ रही।
अब नहीं आ रही आवाज?
नहीं सर।
तो माइक ले लिया मैंने हाथ में, चलो ठीक है। ओके।
ठीक है सर। ओके सर।
हाँ, कंटिन्यू करूँ? नहीं, ये तो नहीं चलता।
ये यस सर, कंटिन्यू कर दी। जी
हाँ,
जी जी,
वो तारीख
क्लियर
कह
हो
रहे हैं
गई।
क्लियर हो गई। तो अब मैं क्या करूँ? शुड आई रिपीट द प्रीवियस स्लाइड्स, क्या करें?
सर आप रिपीट कर लें सर, या फिर एंड में ऐसा करेंगे, एक एंड में एक मरतबा रिपीट कर लेंगे।
अच्छा चलें, ठीक है। इफ देयर बी
ठीक है सर।
टाइम अवेलेबल टाइम तो हम कर लेंगे।
ठीक है सर।
ओके। Okay, this is diagrammatic presentation of anal canal and rectum. You can see over here the this is the puborectalis muscle, and then this external sphincter, which has got three parts: deep, superficial, and subcutaneous. Internal sphincter, and above it is the longitudinal muscle. So these four muscles comprises anorectal ring, which is responsible for continence. So the anorectal ring is the junction between the rectum and anal canal, and it is formed by four muscles: puborectalis, uh, external sphincter, internal sphincter, and longitudinal muscle. Okay, and this is responsible for continence. And the length of the anorectal is around 3 to 4 centimeter. And over here, these are the dentate line. This is the dentate line. So the puborectalis muscle is part of the pelvic diaphragm, and it's part of the levator ani muscle. The other parts are pubococcygeus and ileococcygeus muscle, and it maintains the angle between anal canal and rectum, and it's important component of it forms an important component of the continence mechanism. The external sphincter forms the bulk of the anal sphincter, and it is subdivided into three parts: deep, superficial, and subcutaneous. And it is made up of skeletal muscle, so it's under control, voluntary muscle, while the internal sphincter is the involuntary muscle. Over here you can clearly see the parts of four muscles which forms the anorectal ring over here. This is the external sphincter. It has got three parts: deep, superficial, and subcutaneous part. And this is internal sphincter, which is the continuation of the circular muscle layer of rectum. And above this part is the longitudinal conjoint muscle. So this is puborectalis muscle. So these four components comprise anorectal ring, which is responsible for the continence. And over here you can see that this is the puborectalis part of the levator ani. The other two parts are ileococcygeus and pubococcygeus muscles. These form the levator ani muscle, and it encircles the ring and strengthens the ring, and it forms the angulation. It supports the angulation of the rectum and responsible for the continence. This internal sphincter is the continuation of the circular muscle coat of the rectum, and it's 2 to 5 millimeter thickened. And it's involuntary. It stays in the tonic state of the contraction. It's involuntary muscle. So the difference between the external sphincter and internal sphincter is this: internal anal sphincter is involuntary muscle, and external sphincter is the voluntary muscle. And it commences from where the rectum passes through the pelvic diaphragm and ends above the anal orifice. And its lower border palpable at the intersphincteric groove. So these are the salient features of the internal anal sphincter. The main difference between these two are this is involuntary muscle, and the external sphincter is the voluntary muscle under control. And then comes the intersphincteric plane, which is lying. It is a potential space which lies between the external sphincter laterally and medially longitudinal muscle, and below internal sphincter. So it's a space in between two sphincters, and it's a potential space. Actually, it's not a space, but it's a potential space. If something collects in it, and then it becomes a space. And it contains anal glands, which are usually responsible for perianal abscess, because in the glands there are some infection. Going on, some infection is going on over there in the anal glands, and then it converts into abscess, and this space becomes full of pus, and then through this space it travels. This pus travels towards the perianal skin, and over there it collects. So it forms perianal abscess. So importance of this plane is it contains anal glands, and it's a route for spread of the pus. So this is the internal sphincter, this is external sphincter, and you can see this is intersphincteric plane in between these two sphincters. Laterally, external sphincter, medially, internal sphincter, and in between there's a space. And this is so if some like infection is going on over here, then it travels over here and it presents in the perianal space, perianal skin. This longitudinal muscle is the direct continuation of the smooth muscle of the muscle cord of the rectum and provides the potential space for the spread of the infection. So over here again the repetition is there. So internally there's internal sphincter, externally external sphincter, in between is this intersphincteric plane, and above is the longitudinal muscle, and this is the puborectalis muscle, which is a part of the levator ani, along with the other three parts like pubococcygis and iliococcygeus muscles. And through the corrugator cutis, it is connected. This internal sphincter is connected with the skin. And this anorectal ring, check the ring by the DRE. You can feel it while doing DRE, this ring. The anal glands may be found in the submucosa and intersphincteric space in both sides, like in the submucosa and intersphincteric space. And they drain via ducts into the anal sinuses at the level of the dentate line. And the importance of this intersphincteric anal glands is it's a potential source of anal sepsis. So these glands are lying in the intersphincteric space and submucosa, both sides. And if the infection is going on in it, and it can convert into abscess and it can present in the perianal region. Now let's move to the examination of the anal and perianal region, and then we'll move towards the specific diseases like fistula and fissure. So the anal examination starts with inspection, and initially, before you start examination, you have to inform the patient what's going on, and then take the consent, informed consent. Informed consent means that you have to explain the patient what will happen and how the examination will be done. And there has to be an attendant along with while the patient is examined, and then proper position and exposure should be done. So initially you have to inform the patient, then take informed consent, explaining clearly about the examination. An attendant should be around, and proper position and exposure should be done. So usually this digital rectal examination is done in the left lateral Sims position. This is the usual position in which the examination is done, but it can be done in the lithotomy position or prone jackknife, but usually we do it in the left lateral position, which is called Sims position. This is the left lateral position in which the examination is usually done. And this is the lithotomy position in which the surgery is usually done, like perianal surgeries, hemorrhoidectomy, fistulectomy, fissure, all these surgeries are done in this lithotomy position, in which the legs are apart and they are lying over this stirrup, and its access from the surgeon sits here, and the access of the perianal area is done from here. And this is the prone jackknife position, in which the patient is prone and the head is down and the legs are down, and usually the pilonidal sinus surgery is being done in this position while making the buttocks apart. This area of the pilonidal sinus is exposed and surgery is done over here. So these are the different positions which are used. Now, per rectal examination includes inspection, digital examination, and proctoscopy. So, inspection, whenever you expose the patient, you have to inspect first, and a good time should be given for inspection rather than starting with the digital examination. You have to see the actual position of the rectal area, uh, skin as well. You have to see the externally whether any external opening is there around the anus, which may indicate the fistula. Posteriorly, usually, if a patient is complaining of the painful defecation, then a fissure can be seen posteriorly at the 6 o'clock. So you have to examine it very clear, the anorectal area and skin around it. There might be some eczematous change if fistula is there, because of the fistula external opening. The pus keep on coming from that opening, and it may create some like eczema like condition of the skin. So you have to inspect it clearly. Where there might be some third degree hemorrhoids which can be prolapsed, can be seen in that area, and fissure can be seen in that area. So you have to examine it very carefully, and after that you have to put your finger in. That's digital examination with the proper gloving and lubrication, and you have to inform the patient what's going on. And after that, the hemorrhoids cannot be palpated. They can be seen only with the proctoscopy, unless it's a prolapse hemorrhoids which can be seen directly. Otherwise, in palpation, if external opening of the fistula is seen, then along with that, you can palpate the tract or fibrosis up to internally in the ring, in the canal. And if the fissure is there, if you can see clearly fissure in the posteriorly or anteriorly, then you should not proceed for digital examination, because the digital examination will be very painful if the patient of the fissure. So if on inspection something like some wound is seen and fissure is diagnosed, then you shouldn't proceed for digital rectal examination. So on digital rectal examination, you can palpate. If there is some growth inside, then your finger can feel it. Okay, if the impacted feces are there, that you can feel. And in males, elderly males, you are supposed to feel the prostate. And then we move towards proctoscopy. So proctoscopy means, procto means rectum, scopy means visualization. So visualization of the rectum is called proctoscopy. For this instrument is used, which we call proctoscope, and sometimes it is kept in OSCE also, OSCE exam. So it has got two parts. One is the obturator and the other is the proctoscope sheath. This is the sheath, and obturator is inserted inside, and it's inserted along with the obturator in the anal canal. And after that, when it's inserted, then this obturator is removed and a light is put inside the sheath, and then you can examine, like you can examine the hemorrhoids from it on the three sides, like 3, 7, and 11 position, and slowly, gradually you have to withdraw this proctoscope out. Okay, so this is the way how proctoscopy is done. So you need gloves, you need lubrication, you need light and this proctoscope and privacy, and after that you can do this, and you can diagnose hemorrhoids from it, and you can locate the internal opening of the fistula. If the fistula is there, then you can locate internal opening of the fistula through this proctoscope, and you can visualize the not almost the whole rectum, but part of the rectum can be visualized through it. If there's any polyp inside, any growth, you can see it through the proctoscope. Specific investigations regarding perianal diseases are sigmoidoscopy. Sigmoidoscopy can be done. So in the sigmoidoscopy, you can see the whole, along with the rectum, anal canal, you can see the sigmoid colon as well. And usually it is done with the flexible sigmoidoscope, can be done with the rigid sigmoidoscope. And you can visualize sigmoid colon along with the rectum. Then if required, then colonoscopy can be done. This colonoscopy means the visualization of colon. Like sigmoidoscopy means visualization of sigmoid colon. And the colonoscopy means visualization of the colon. And this visualization is done up to ileocecal junction, and a little terminal ileum. Part of the terminal ileum can also be seen through this colonoscope. If it is done properly, then the scope travels from the rectum into the sigmoid, then it goes to the left colon, then through the left colon it goes to the transverse colon, and then ascending colon, and then cecum visualization, and through the ileocecal junction, this scope can go into the terminal ileum. Part of the terminal ileum can also be seen through it. It's very important in the colonic cancers or polyps. So now we'll discuss perianal diseases. So up till now we have done this examination and anatomy. And before we start the perianal disease, you should make an approach, like clinical approach, how the patient presents in OPD. The patient presents in OPD with usually with a bleeding, with a history of bleeding PR, or painful defecation, or the pus coming from that area, from the anal canal or from the side of the perianal disease, perianal area, or there might be some excruciating pain in that area, which indicates towards the abscess. So patient will come with these 3 or 4 symptoms, and through that you have to diagnose where the patient is history is going. So if the patient is presenting with the bleeding PR, then you have to take the detailed history of the bleeding, that when the bleeding comes and what is the color of the bleed. It's red or clotted, blackish. This is there is a specific importance of this color, because the fresh red blood means that the blood is coming from the distal part, and clotted means it's coming from the proximal part, upper part. And if the fresh red bleeding is there, then in your mind comes 3-4 diseases like hemorrhoids, fissure, or any growth which is lying very low down. And if the clotted blood is coming, then it may come from the upper GI, it may come from the colon. And if there is a painful defecation or painless, painful defecation is like painful diseases, and patient presents with the pain, then which are the diseases which comes in your mind? These are abscess or proctitis or fissure. And painless diseases are hemorrhoids or maybe tumor. And then you move towards the approach is same as you see other patients, like abdominal pain or vomiting. Or first of all, you have to take history, a detailed history, and then you should move towards the examination. In detailed history, you have to take the detailed history of the bleeding, detailed history of the pain, and then you have to move towards the examination. An examination, I've already explained that it's an inspection, digital rectal examination, and visualization, that is proctoscope. This is usually done, these three things can be done in outpatient department, and if specifically, if any specific investigation is required, then you can send the patient for sigmoidoscopy or colonoscopy. So the perianal diseases to be discussed are perianal abscess, anal fissure, and fistula in anal. So I'll take in detail one by one. Perianal abscess. It's a type of the anorectal abscess. Anorectal abscesses are other abscesses as well, like ischiorectal abscess, supralevator abscess. I'm concerned with the perianal abscess. So it's confined to the perianal space. An abscess, which is the collection of the pus in the perianal space, is called perianal abscess. Okay, so it's a type of the anorectal abscess which is confined to perianal space. So these are the different types of the abscesses which can be presented. Like this one, the subcutaneous abscess is perianal abscess. There may be supralevator abscess, which is above the levator ani muscle. There may be ischiorectal abscess, which is present in the ischiorectal fossa, lateral to the external sphincter. It may lie over here in this space. So we call this ischiorectal abscess if it is laterally placed. When it is near to the anal verge, then we call it perianal abscess. This is intersphincteric abscess between the two sphincters, because over here glands are there, anal glands are there. These are the and anal glands are also present over here in the submucosa. So from here the pus can travel over here. From here the pus can travel here. So there are different types. These are the different types of the anorectal abscesses. This perianal abscess, subcutaneous abscess, intersphincteric, supralevator, and ischiorectal abscess. I'll discuss. I'll focus more on the perianal abscess. Externally, this abscess is seen like this: a palpable mass which is close to the anal verge, and patient is in severe pain throughout the day and night. Patient doesn't get relief. If the patient gets any analgesia, then for a time being, patient can get relief. Otherwise, he stays like in pain the whole day. He cannot sit. He cannot like walk easily. So, if there is persistent pain in the anal area throughout, then it means that the patient is definitely having some abscess. It's constant pain, and along with pain, patient may present with a fever or malaise. And when the patient is examined, the patient may present with this type of the swelling. In this type of swelling, also the digital rectal examination should not be done. Otherwise, it hurts the patient and it's so painful. So the perianal abscess, the theory behind is the cryptoglandular theory. An infection of the gland is there, anal gland, and pus travels along the path of the least resistance, may spread correlated to present as a perianal abscess. So the pus infection starts in the anal gland, whether in the intersphincteric anal gland or submucous, and it may travel in the intersphincteric space, and through that the pus goes it stays in the perianal space and forms a perianal abscess. The most common organism for the perianal abscess is E. coli, and usually it is the cryptoglandular origin from the glands, 95%. And how the patient presents? Patient presents with a severe pain, which is increasing day by day, and it's localized over there and in the perianal area, and continuous pain, and patient doesn't get relief of it. Patient is in agony throughout, and patient may present with the pyrexia and malaise. So on examination, you can see as I've shown you the previous picture, that the patient is presenting with the perianal area, swelling of the perianal area, and that's the tender perianal swelling. Tender means that whenever physician touches it, the patient creates the pain is there. So there's a difference between the tenderness and pain. The pain is symptom, which the patient will tell you that I'm feeling so much pain, and this tenderness is this sign which is elicited by the physician. So whenever the patient is touched or examined, then patient will feel pain. So this is a tenderness. So there's a little difference between these two. The pain is the symptom, and the tenderness is the sign which is elicited by the physician. And whenever it's a hot, like whenever we examine the swelling, remember we have to see it. What is the location? Where anywhere, if the swelling is anywhere in the body, then some time should be given for inspection. That what is the anatomical site of that swelling? What is the size? What is the shape? What is the color over it? And if it's hot, like this is inflammatory swelling, it means that it will be a red swelling. It has to be a red swelling, okay? And whenever you touch, it will be hot, and tenderness will be there. So it moves. So the diagnosis comes that there's some infection is going on in that, and it fulfills all the criteria of the inflammation. It's painful. It's hot. It is tender. So these are the characteristics of perianal abscess. The differentials are maybe abscesses connected with the pilonidal sinus, and the treatment of any abscess is incision and drainage. Incision and drainage. You have to incise that swelling and drain all the pus which is present in, and break the loculi, and then keep the patient this wound open. And patient will continuously, take sitz bath, hot bath, and he has to keep this the wound open, and daily washing is there, and maybe some gauze can be applied over there to avoid oozing. And remember, whenever an abscess is operated, stitches are not applied. The wound is kept opened, so that after that the wound will heal. If it is closed, then again the same atmosphere is there, and the abscess will form again. So it has to open air has to be given to the wound. So anaerobes cannot grow in it. So the treatment is incision and drainage. If it is a small, can be done under local anesthesia, and if it's large one, very painful, that area is also very painful, so it should be done under spinal anesthesia or general anesthesia. Ideally it should be done so that you can break the loculi easily, you can drain it properly, and the patient will be pain free. Otherwise, in local anesthesia, absorption of the local is difficult, and applying local anesthesia along with syringe with this injectable is very painful. So better to do it under local general anesthesia or spinal anesthesia. A cruciate incision is given. A cruciate means at the most fluctuant part. Cruciate means cross, like one vertical incision and one horizontal incision. So the whole rounded area of the skin which is involved and which may become necrotic or unhealthy, it should be taken out and wound should be opened. And this pus is sent for culture, and accordingly, antibiotics can be given. It's also controversial that if the pus is drained and abscess is drained, then you can avoid antibiotics as well, because as the wound is open and daily dressing will heal the wound. And if there's no systemic manifestation of the abscess, then one school of thought is that no antibiotic should be given. The other school of thought is that it should be given according to the culture and sensitivity, so that it will heal early and infection will go away early. This is the anal area, and over here is the abscess. You can see the abscess. Then the cruciate incision is given. Cruciate means one vertical and one horizontal incision, and then these ridges, these skin ridges should be cut this way, this way, this way, and this way. So the whole hole is formed like this. The hole is formed. So these skin ridges are cut. So this cruciate incision is given like this, and then these ridges are cut, and this hole is made, and this finger is inserted in it to break the loculi of the pus, of the abscess. And then this wound should be kept open. Just a gauze placement should be done over here, and then patient is advised to take hot sitz bath, keep a gauze over here, and patient can move, can do his routine life, and he'll be pain free. Just pain or mild pain of the wound will be there, otherwise that excruciating pain which because of which patient cannot sit will be over. Okay, so this cruciate incision is given, then these ridges are cut, and then loculi are broken of the abscess, and then patient is asked for sitz bath, and cultures according to culture and sensitivity, antibiotics can be given. So now let's move towards the anal fissure. This anal fissure is it's a wound. It's a longitudinal split in the anoderm of the distal anal canal, which extends from the anal verge proximally towards or not beyond the dentate line. So in between below the dentate line, a longitudinal split is seen in the distal anal canal usually, and usually it is a posterior anal fissure. And frequent site is the posterior midline of the anus. So if the patient is in the lithotomy position dorsally at the 6 o'clock, this split in the skin can be seen. Over here you can see that the split starts from the anorectal anal verge, and it reaches below it ends below the dentate line. Over here you can see this split, and this is the fissure, and because of this the patient presents with painful defecation. The pain stays with the patient half an hour or 1 hour after defecation. So patient is very afraid of defecation. This is the common presentation of the fissure, and it starts with the anal verge and it ends below the dentate line, and usually it is present in the posterior part, dorsal part, 6 o'clock. Over here you can see the external sphincter, internal sphincter, anus rectum, and over here you can see this split, this fissure. The causes are strained evacuation of a hard stool. Whenever hard stool is passing, then behind is the bone sacrum, and in between is the anal canal. So the hard stool spoils the mucosa, and it may create a wound which is called fissure, and If there's repeated passage of the diarrhea, it can also insult it, and fissure can be produced. And interior anal fissures are usually seen in the woman after vaginal deliveries. And clinical feature, I have already explained you. The painful defecation is there, severe anal pain associated with the defecation, and this pain stays during defecation and after also, like half an hour to 1 hour after defecation, it stays there. So patient is very afraid of going for defecation. And there might be fresh passage of the fresh blood. So when as there is a wound and the stool is passing through it, so it also creates some friction, and it might produce some fresh bleeding from that wound while passing this stool, and it will be red blood, fresh blood, and it will be along with the defecation, like along with the stool. And but in hemorrhoids, you can see the blood is coming after defecation, and the blood and the defecation is not painful in case of the hemorrhoids. But in fissure, the defecation is painful, and the blood is coming along with the stool. So this is the differentiating points between the hemorrhoids and fissure. And this pain stays with the patient during defecation and half to 1 hour after defecation. This is the common presentation of the fissure in ano, and there's passage of the fresh blood also. Sometimes not. But the usual presentation is pain during defecation, and pain stays after defecation as well. And the chronic fissures, if the patient stays with this condition for more than 6 months, then the acute fissure may be converted into chronic fissure. It's characterized by hypertrophied anal papilla internally and a sentinel tag externally. So internally there will be a hypertrophied anal papilla, and externally there will be a sentinel tag. Sentinel tag means a guard. Sentinel means a guard. So a tag is like produced from the mucosa, and it covers the fissure. It covers the fissure. So it works like a guarding of the fissure, and this indicates that the patient is having chronic fissure. Okay, so if the sentinel pile is we call it sentinel tag or sentinel pile. Sentinel means guard, and it's guarding the fissure, this wound which is present dorsally. So if the sentinel pile is seen on examination, then it means that patient is having chronic fissure. And if there is no sentinel pile, just a breach in the epithelium starting from the anal verge towards the dentate line, then it means the patient is having acute fissure. Okay, it's clear? If the patient is presenting is having acute fissure, then the patient will, when you examine the patient, there will be a split in the epithelium, which is starting from the anal verge, ending before dentate line, and there will be no sentinel tag or sentinel pile. If the sentinel pile is there, it means that the patient is having chronic fissure. So the treatment is different for chronic and for acute. That is why this difference has to be appreciated. Itching secondary to irritation from the sentinel tag. There might be some, the patient might present with the itching because of the sentinel tag, but usually patient present with the painful defecation and bleeding. It can affect both genders, elderly and infants, and tear fissures are in 10% of the women it can be seen. Can produce with the fissure. Patient management is the conservative management for acute patients. For acute patients, conservative trial can be given for about 6 weeks. The patient's dietary habits should be changed and add some fiber to the diet to bulk up the stool. And things which should be avoided are biscuits and bread should be avoided. And patient should be encouraged to take more fiber, vegetables, fruits, softness can be given, so the passing of the stool will not be so much painful. Adequate water intake should be given to the patient. Warm baths should be given. These all are the conservative measures which should be taken for the patients with the fissure anal. And some topical local anesthetics like 2% xylocaine jelly can be applied before, while going for the defecation and after defecation. So it will reduce the pain. And the mainstay is the 0.2% GTN, glycerol trinitrate. It is applied 2 to 3 times to the anal margin, and it causes a relaxation of the internal sphincter, because usually in the anal fissure the internal sphincter becomes contracted. Spasm of the internal sphincter is there. To relax the internal sphincter, this smooth muscles are there. So this GTN, glycerol trinitrate, 0.2% can be given, can be applied at the anal margin 2 to 3 times. But it should be a precaution should be taken that while using this GTN, after applying GTN to the anal margin, patient should lie down for about half an hour, at least half an hour. Otherwise, postural hypotension can be like experienced by the patient, because it decreases the it causes hypotension, and usually the postural hypotension. If the patient is standing, then patient might have vertigo and headache. So after applying this GTN 0.2%, patient should lie down for at least half an hour every time. So these are the conservative management. This is the conservative management of the acute anal fissure. And this GTN, glycerol trinitrate, should be applied for about 6 weeks. 6 weeks. Then it can be, it can be it can cure the patient along with these measures. And in future also, this dietary habit should be continued. These all things should be continued in future, so it can be so the further episode of the fissure can be avoided. But if the patient does not respond to the conservative management, or patient is having a chronic fissure, the patients with the chronic fissure does not respond to conservative management, they should be of surgery. If the patient is having, and I've told you the difference between acute anal fissure and chronic anal fissure. In chronic anal fissure, there will be a sentinel pile, a anal tag, which will be covering the this fissure, and if the chronic fissure is there, then conservative trials are not will not be successful. Patient should undergo surgery. And if the conservative trial for acute fissure is not successful, then patient should undergo for surgery. So surgery is the definite treatment. And the common surgery which is done for this fissure in ano is the lateral anal sphincterotomy. Lateral anal sphincterotomy. Park anal retractor is inserted, and the this anal sphincter is made taut, so you can feel it through the digital rectal examination, this anal ring, because already it is in a spasm. And when you insert park anal retractor in the anal canal, and then it can be felt very easily with the finger. So over it, this anal sphincter should be cut from there. Skin incision is given, and then the sphincter is exposed, and then it should be cut. Then the patient, the sphincter tone becomes decreased, it goes away, and canal is relaxed. And then as it becomes relaxed, then the healing of the dorsal fissure is automatically done. So this is the lateral anal sphincterotomy. Complications of it are hemorrhage, hematoma, perianal abscess can be formed, and minor degree of the anal incontinence can be seen. Well, it's rarely done. It's rarely seen. Usually the patient ends up with, a good release of his symptoms and becomes pain-free. The other operative like maneuver is the forceful dilatation, sphincter dilatation. But in previously it was very popular, but nowadays we are not doing it because it damages the internal sphincter at multiple sites. In the lateral sphincterotomy, only one site of the clearly cut, the sphincter is clearly cut, internal sphincter. But whenever a forceful dilatation is done, old surgeons are still doing it. When forceful dilatation, it may damage the external sphincter also, along with the multiple sites of the internal sphincter, and there is risk of incontinence following this procedure. So it has become unpopular. The other procedure which can be tried, which is tried, is the posterior division of the exposed part of the, because posteriorly already the skin is cut, and this sphincter can be visualized easily posteriorly. So it can be cut without giving another extra cut to the skin, as posteriorly already exposed. This internal sphincter is already exposed, so you just have to make a cut over it. But the problem is that the healing of this wound is very delayed, and it ends up with the buttonhole deformity of that area. So this procedure is also avoided. So mainly the gold standard is lateral anal sphincterotomy for the treatment of the surgical treatment of the of this disease. See over here, this ring can be felt. Like this is the anal speculum is inside and making the taut this ring. So this is the internal ring. You can see this is the internal ring. The whole surrounding internal ring can be felt through the finger, and skin incision is given, and then this sphincter can be exposed outside. So you can see this sphincter can be exposed outside, and then it should be cut, and then this wound can be closed or can be kept open after doing hemostasis. So these are the steps of the lateral sphincterotomy, and posterior sphincterotomy should be done here, posteriorly, near the over the fissure. Over the fissure, the skin is exposed, and this sphincter can be seen and cut over here, but it ends up with the delayed healing of the wound. So usually this procedure is done. This is called lateral sphincterotomy. You should at least remember the name of the procedure. Lateral sphincterotomy. This is the internal sphincter, and it's cut over here. After filling it, the finger is inserted, and through this knife, this is cut. Now let's move to the fistula ano. I think you must be tired. I am also, but we have to continue as the topic finishes. So fistula ano means, what is the difference between fistula and sinus? Sinus is a blind tract which has got one opening that is usually on the skin. But the fistula is a double, it has got a double opening. One opening is lying over the skin, the other one is internally in the anal canal or in the rectum. So it's a communication, it's a tract which is between two openings. So the definition is, it's a chronic abnormal communication. It's an abnormal communication between two cavities and lined by granulation tissue. So internally, it is opening in the anorectal lumen, like in the anal canal or rectum, and externally, the opening is lying in the perineum or buttocks. Okay, so it's a communication, abnormal communication between two cavities like skin, and the one opening is lying over the skin, and the other opening is lying in the anal canal. And the associated conditions are, like, if it's not a simple fistula ano, patient may have Crohn's disease, and that manifests with the fistula. Or tuberculosis, patient is having tuberculosis or erratic actinomycosis. Patient may present with the this fistula ano, and there might be some reason it might be secondary. Means the fistula ano usually is primary. Okay, and if it is secondary, that it might be because of these diseases. The patient may present with the fistula ano, like Crohn's disease, tuberculosis, actinomycosis, and these are rare. Usually, the patient presents with the primarily. It's a consequence of the perianal abscess, which is untreated. It just gets ruptured, and it forms communication between the canal and anorectal opening, makes anorectal opening, anal canal or rectum, and externally on the skin. So usually it's the consequence of the non-healed abscess or untreated abscess. The clinical features are usually from the external opening. The patient presents with a purulent discharge, which may be bloody, and pain is there. It increases until temporary relief can occur. So usually what happens, an opening is there outside from the perianal region. Okay, and it closes. When it closes, what happens? The pus starts accumulating below it, and a swelling appears, and the patient feels pain. And then what happens? The opening gets opened, and the pus comes out through that opening, and the patient gets a relief of the pain, but continuous discharge comes from that opening. And if the conservative treatment can be given, it might close at that time temporarily, and again the accumulation of the pus is there, and then again this sequence keeps going on till we treat this condition operatively. Okay, so otherwise what happens? Again this cycle starts. This opening closes, the pus starts accumulating below it, and then patient starts feeling pain, and after taking some medication or some hot bath, it may open the external opening, and pus comes out, and patient gets a relief of the pain and start pouring pus, and then after some days or some weeks it stops. but it's not the and patient is relieved of the symptoms for some period like month, 2 month, 4 months, and again this cycle starts. So this is the way how the fistula patients present, and there will be some previous episode of the sepsis and rectal sepsis which settle down incompletely or completely spontaneously or with antibiotics, or maybe after drainage of the proper drainage also patient may present with its fistula. But usually if the previous episode of the sepsis is not dealt properly surgically, like it ruptures spontaneously or with antibiotics it is healed, then it may end up with the fistula. But sometimes even after surgical drainage of the abscess, fistula may occur, but usually not. Usually when it is not dealt properly, this abscess, previous attack of the abscess, then it may end up with the fistula. The passage of the flatus or feces through the external opening means that the opening is very high, like in the rectum. That they'll call high fistula. If the opening is lying above the anorectal ring, then we'll call it high fistula. What's the Park's classification of the fistula? There are 4 types of the fistula are there. And they are usually from the cryptogranular infection, which is already described. There may be intersphincteric fistula, there may be transsphincteric fistula, suprasphincteric fistula, or extrasphincteric fistula. Maybe superficial fistulas. Superficial fistula is like this. This is a superficial fistula, and it is coming from the anal canal, ending over here in the perianal area. The other one is the intersphincteric fistula. Intersphincteric means this is the intersphincteric groove. This one. This is the external sphincter. This is internal sphincter, and it's arising from. It's ending over here below the dentate line over here. It's arising from here. So it's traveling the intersphincteric groove, and external opening is there in the perineal area, but it's traveling in the intersphincteric groove and ending in the dentate line. This is the superficial one. This is the intersphincteric, means in between the sphincters. The third one is the transsphincteric. Transsphincteric means that its opening will be a little lateral. If the opening is very near to the anal verge, then it means that this is superficial or a sphincteric, intersphincteric. But if the opening is lateral, away from the anal verge, it means that it is a transsphincteric or extrasphincteric, suprasphincteric. So it is crossing both sphincters. That is why it is called transsphincteric fistula. Also the space in between, and then ending below the dentate line. So these all are low fistulas. Okay, but this is high fistula. The suprasphincteric fistula is above the sphincters, both sphincters, and it's lying more laterally. So if the external opening is more away from the anal canal, it means that it might go in favor of the suprasphincteric or extrasphincteric or the transsphincteric. And superficial and intersphincteric, they will present with the nearby. The opening will be near the anal verge. So there are 5 types of the fistula. Superficial fistula, whose opening is very near to the perianal region, and it is ending below the dentate line. This is the superficial one. This is intersphincteric. It is traveling in the intersphincteric groove, ending near the perianal area, near the inner verge, and its track is entering into the below the ring below the Hilton line. This is a dentate line ending over here. Then comes the transsphincteric. It crosses. It is away. The external opening is away from this anal verge, and it is traveling through the external groove, intersphincteric groove, internaling, and then opening in below the dentate line. These three are. The other one is the suprasphincteric, means above the sphincter complex. Like this is the external, this is internal sphincter. It's lying above the sphincter, ending laterally away from the anal verge, but it is also ending below the dentate line. Then the last one is the extrasphincteric, and it is crossing the levator arena and ending into the rectum. And this is high fistula. And this high fistula should be dealt with the seton placement. Up to here, this skin is cut, and from here we apply silk sutures in the tract and take out the suture like this, and slowly and gradually it cuts it and overlaps, and so to avoid, because if we cut it from here, like for fistulotomy or fistulectomy, then there are high chances of incontinence. So for this is a complex fistula, high fistula, and its treatment is different from the other these four types. Okay, for this we apply a seton. Seton means silk, thick silk is applied. Up to here it is cut, like fistulotomy, it's open, and when the muscles starts, then from it the suture is passed through this tract, silk sutures, and it's taken out from here back to the skin, and where it is tied, and gradually after 2 weeks it is tied again and again, so it cut through, and behind this healing is done, and it goes in, and it's taken out after four or five explorations, tightening procedures. So it's like a stepwise treatment for high fistulas. And for low fistulas, we use fistulotomy or fistulectomy, which I'll explain to you. So intersphincteric fistula is a result of perianal abscess, and it's lying in this tract, as it is explained in the previous diagram as well, that it starts over here near the perianal, anal verge, and travels in the intersphincteric groove, and then ends in the anal canal below the dentate line. And it's because of the result of the perianal abscess, and the common course begins with the dentate line and ends over here. Terminates in the perianal skin or perineum, and it travels in the intersphincteric space. And 70% of all anal fistulas are intersphincteric. Transsphincteric, this is the transsphincteric. It starts with the dentate line and goes across internal sphincter and then intersphincteric groove space, external sphincter, and then comes out a little lateral to the anorectal verge. And it results over here from the ischiorectal abscess. Over here, this is the ischiorectal fossa. And if abscess is over here, then it may end up with it's not healed properly, then it may end up with this transsphincteric fistula, this ischiorectal abscess. And 25% of the anal fistulas are transsphincteric. Suprasphincteric are very rare. Arises from the supralevator abscess. If some abscess is lying over here, supralevator abscess. Supralevator means that above the levator ana, if the abscess is there, it ends up it doesn't heal properly, then it may go in and make an opening in the rectum, and externally it is continued with the Ischiorectal, like a skin over the ischiorectal fossa, and end up in over here in the external opening. So this is supra-sphincteric fistula. This is the supra-sphincteric fistula. This is extra. Passes from the internal opening at the dentate line, and it is crossing the internal sphincter, then in the groove, and then external sphincter, and then comes out. It's very rare. 5% of the patients present with this suprasphincteric fistula. And then extrasphincteric fistula. This one is the extrasphincteric fistula. Arises from the foreign body penetration of the rectum. It arises from the foreign body penetration of the rectum, draining through the levators and penetrating injury to the perineum. Or maybe Crohn's disease or carcinoma treatment, the patient may produce this extrasphincteric fistula. In common courses, it runs from the perianal skin via the ischiorectal fossa, tracking upwards through the levator and ending in the completely outside the external mechanism, sphincter mechanism, and connected with the without connection, and it ends up in the rectum directly. This ends up in the rectum directly. And clinical assessment, the key points which should be remembered: the site of the internal opening, site of the external opening, course of the primary tract, and presence of the secondary extensions, and presence of the other conditions complicating the fistula. So you have to locate. External opening can be seen easily on inspection, whether it is near the anal verge or away from it. More away from it, then there are chances that it will be some other fistula, not superficial fistula. Superficial fistula and intersphincteric, they will present very external opening will be very near to the anal verge, and the tract can be felt while examining. If you make like palpate the tract over the external opening, you can palpate the fibrosis, which is going superficially or deeply going in. Then a good Saul's rule is made. If a line is drawn when the patient is in lithotomy position, line is drawn from the both ischiorectal tuberosities and dividing the anal canal into two parts, and ventral and dorsal part. Okay, so if a line is drawn like this, then the external openings which are present above this line, which is drawn between the two ischial tuberosities and dividing the anus into two parts. If this external opening is above this line, then the internal opening will be very near to it and is straight. These are the law. This is the law. If the external opening is anterior to the line, then the fistula ends directly into the anal canal, and it's a short tract fistula. But if the external opening is behind this line, then there will be a complex travel of it will be incurved. It will not go directly. Usually it's not seen, it will not have a direct like passage into the anal canal, but it might make curves, and it may present with more than one openings, this fistula. So if the external opening is posterior to line, understand, like if the line is drawn from both ischial tuberosities and the anal canal is divided into two parts, one is the anterior, the other one is the posterior, and if the opening is external opening is lying interior to it, then there will be a straight fistula, and it will be opened directly internally in the anal canal. Straight tract will be there. And if the external opening is lying behind the this line, which is drawn between the two ischial tuberosities, then the curve, it will be a curved, like track of the fistula will be curved. It will be a complex one. So difficult to deal during surgery. So this is good Saul's rule. So how the clinical assessment should be done? The full medical history should be taken uh, to exclude the other diseases like Crohn's disease and actinomycosis and tuberculosis, and also the proctosigmoidoscopy should be done to see any other disease of the colon. And then palpable induration between internal and then duration, induration should be felt from the external opening traveling into the anal canal, and that will lead you to the track. So if the track can be felt in during EUA, like examination under anesthesia, or in during digital rectal examination, when you will palpate the external opening, over it there will be indurated area can be seen. The other area will be soft, and this fibrous track will be a little harder, and you can feel it up to the anal canal, and then the track can be felt. And good Saul's rule should be kept in mind that the openings which are lying anterior to the line, they will be having a straight track, and the openings, external openings which are lying below the line drawn through the ischial tuberosities, the track will be curved. Full examination under anesthesia should be done, and this examination should be repeated under anesthesia as well. The examination which is done, digital rectal examination, can be repeated under anesthesia as well to confirm your findings. And to locate internal opening, diluted hydrogen peroxide can be injected through the external opening, and proctoscopy or anal retractor can be placed in the anal canal, and then bubbles will come. If the hydrogen peroxide is injected through the external opening, then from the internal opening it will come out, and bubbles will start coming from the internal opening. So you can locate the internal opening with the help of the hydrogen peroxide. It can be located with the help of the other dye like methylene blue or gentian violet to locate or a probe can be blindly passed in the external opening, and then it will come out if the force should not be applied while passing probe, because it is a crude way of demonstrating internal opening. Because if the pressure is given, then it can come out from any part of the anal canal. So it should be gently inserted and gently taken out. So these are the different ways of locating internal opening. Sometimes it can be seen easily with the papilla growing near the internal opening. If it is not visualized, then you can apply the hydrogen peroxide diluted, inject through the external opening, it will come out, the bubbles will be seen coming out from the internal opening, or a dye can be passed and seen coming out from internally, or a probe can be passed through the external opening. So operative measures are fistulotomy, fistulectomy, and ketone placement. Fistulotomy means the fibrous tract is laid open from its termination to its source. The fibrous tract, which is starting from the external opening, ending in the internal opening, in between, the structures should be cut and the tract should be laid open. Fistulotomy means laying open of the tract. It involves the division of all the structures which are lying between these two openings. This is therefore applied mainly to intrasphincteric fistulae and transsphincteric fistulae, and also superficial fistulae. And then a large wound will be created. So it can be marsupialized, and the size of the wound will be reduced. Marsupialized means that skin near the wound should be stitches should be applied over the skin near the wound, and it will reduce the wound size and it will speed up the healing, and it will not allow to close the wound. uh, it will make the margins away from each other, and the wound will heal through from the base. Then fistulectomy, this technique involves coring out of the fistula, usually by diathermy and cautery. In this, the whole fistula tract is excised. The whole tract is excised. And then the third one is the ketone placement. If the internal opening is lying high up, then a ketone is placed. As I described, this ketone means that silk sutures are tied in the internal component. External component is excised or opened, and the internal components are tied so that to avoid incontinence. Otherwise, if the sphincters and rectal ring is cut, then the patient will go into the permanent incontinence. To avoid that, ketone is placed. Look at it. This probe is passed from the external opening. It's coming out from the internal opening, and then this wound is cut from here. So this skin will split here and there, and a big wound will be produced. And to marsupialize, stitches over here at the edges are given, 1-2 interrupted stitches at the edges, and then wound will heal from the base and the skin will come. So a probe is passed and a cut will be placed over here. So this is fistulotomy, opening the tract hole, the whole tract. And this is fistulectomy. This probe is passed from the external opening, coming out from the internal opening. You can see it. It's coming out from the internal opening, and then this whole tract is cut, and the wound is kept opened, and this is the fistula which is taken out. I think it's enough for today. If you have got any questions, you can ask. I'll try to reply. Do you have any questions?